In this video, we will discuss ASPREE trial. This trial was undertaken to evaluate effect of aspirin in reducing cardiovascular events in the elderly individuals. Daily use of oral 100 mg entry-coated aspirin will extend disability-free survival in healthy elderly individuals was the primary hypothesis which was proposed in this trial, and thus the objective of this trial was to evaluate potential primary prevention benefits versus risk associated with the use of daily low-dose aspirin in these healthy elderly individuals. So it was a double-blind, randomized, placebo-controlled primary prevention trial which was undertaken in community settings in Australia and in the USA. Over 19,000 relatively healthy elderly participants were randomized to receive either entry-coated aspirin 100 mg daily or placebo, and these patients were followed up for a median period of 4.7 years. So relatively healthy individuals who were free of dementia, disability and cardiovascular disease events aged 70 years and above in case of non-minority men and women, and aged 65 years and above in case of US minority, that is African American and Hispanic patients, and who have provided informed consent were included in this study. Individuals with current use of aspirin for reasons other than secondary prevention were allowed to enter the study after agreeing to discontinue aspirin. A history of a diagnosed cardiovascular disease event like myocardial infarction, heart failure, angina pectoris, etc., a clinical diagnosis of atrial fibrillation, an absolute contraindication or allergy to aspirin, current use of aspirin for secondary prevention, current continuous use of other antiplatelet agents or anticoagulant drug, a systolic blood pressure of above 180 millimeters of mercury, or diastolic blood pressure of more than 105 millimeters of mercury, serious illness likely to cause death within the next 5 years, a recurrent condition with a high risk of major bleeding, anemia, history of dementia or 3MS score of less than 77, severe difficulty or inability to perform any of these 6 CATS activities of daily living, field-taking compliance of less than 80% during a 4-week placebo run-in phase, and current participation in an ongoing clinical trial were the exclusion criteria. Chronic use of NSAIDs was not an exclusion criteria. Now let's move through the study points of this trial. Disability-free survival, which was defined as survival free from dementia or persistent physical disability, was the primary endpoint, while the composite of first occurrence of either death from any cause or dementia or persistent physical disability was the primary composite endpoint. Now let's go through the secondary endpoints of this study. 3 individual components of the primary endpoint, that is death from any cause, dementia and persistent physical disability were the secondary endpoints, while fatal and non-fatal cardiovascular disease events, fatal and non-fatal cancer, mild cognitive impairment, depression and major hemorrhage were the other secondary endpoints. Now let's go through the results of this trial. In case of primary composite endpoint, the event rate per 1000 person years was 21.5 in case of aspirin group compared to 21.2 in case of placebo group. So there was no significant difference between two groups from primary composite endpoint of view. Similarly, the individual components of the primary composite endpoint, that is death from any cause, dementia, and persistent physical disability, did not differ significantly between two groups. Among primary endpoint, the 50% of events were death from any cause, 30% were dementia, while remaining 20% were persistent physical disability. Now moving to the secondary endpoints, the rate per 1000 person years in case of death from any cause was 12.7% in aspirin group compared to 11.1% in placebo group. Thus, this apparently higher all-cause mortality observed with aspirin use was primarily because of cancer. However, when the p-value was corrected for multiple comparisons, the difference observed was not statistically significant. Further, the event rates of dementia and persistent physical disability did not differ significantly between two groups. So now moving to the outcomes of cardiovascular endpoints. The cardiovascular endpoints like cardiovascular death, major adverse cardiovascular events, fatal cardiovascular disease, hospitalization for heart failure, fatal or non-fatal MI, fatal or non-fatal ischemic stroke did not differ significantly between two groups. Now moving to the safety outcomes of major hemorrhagic events. In case of major hemorrhage, the event rate per 1000 person years was 8.6 in aspirin group compared to 6.2 in placebo group. Similarly, in case of any intracranial bleeding, the event rate was 2.5 in case of aspirin group compared to 1.7 in case of placebo group. Further, in case of upper GI tract bleeding, the event rate was 2.1 in case of aspirin group compared to 1.1 in case of placebo group. Thus, the rates of major bleeding, any intracranial bleeding, and upper GI tract bleeding were significantly higher in the aspirin group, and this bleeding risk persisted throughout the course of the therapy. However, the rates of fatal bleeding, including fatal major hemorrhage and fatal stroke, did not differ significantly between two groups. So now moving to the interpretation and the conclusion of this trial. In this trial, it was observed that aspirin did not improve or prolong disability-free survival or results in lower risk of cardiovascular disease over a period of 5 years. Thus, the daily use of low-dose aspirin as primary prevention measure was not found to be beneficial in healthy elderly individuals. Further, no significant difference between two treatment groups was observed across different subgroups. In addition, the significantly higher risk of bleeding, predominantly excess intracranial and upper GI tract bleeding, was observed with the aspirin use, and this increased risk of bleeding persisted throughout the trial period. In addition, the apparently higher all-cause mortality, predominantly because of excess cancer mortality, observed with the aspirin use could be a chance finding, but it requires further evaluation. So these are the references you can go through for further details.